There we go. So just very quickly, I think we're all familiar with prognostic factors, but I just really wanted to draw a careful distinction. So of course, prognostic factors are things that are associated with the risk of an outcome. So we can think of things like cholesterol and risk of cardiovascular disease. Predictive factors are quite different. They're variables that are associated with the effect of some intervention on the risk of an outcome, right? So they're tied to an intervention. So this can include things, this comes up a lot in cancer. There's this huge focus on getting the right therapy to the right patient. And so one example is there's a new prostate cancer signature, and it can it correlates with benefit from androgen deprivation therapy. And so you can see just this very recent paper on the left, you have people who are at the high level of this marker they have called Decipher. And you can see that there's a big benefit for androgen deprivation therapy plus docetaxel. And then on the right, people who are at the lower level of the marker, there's really very little benefit. So these factors are used clinically in very different ways. You know, if somebody comes in with a set of prognostic factors, say again for cardiovascular disease, we might use those for things like risk stratification, risk management. You know, are we going to prescribe a statin to this person? Are we going to monitor them more frequently? But again, predictive factors are very much tied to a certain intervention, and so they're used for intervention selection. So that's just this idea of deciding whether or not a given individual should receive a given intervention. We'll do this now. And so the question becomes, how does the risk of the risk with the intervention compare to risk without the intervention? And really this difference is just the individualized intervention effect. So we want to deliver the intervention for folks who are going to receive a benefit from the intervention and not give it to people who are going to receive no benefit. Of course, considerations of toxicity, financial considerations, all those things also can come into it, but for right now, we'll just consider it a question of, is there a benefit in terms of risk of the outcome? The factors are also evaluated differently, so prognostic versus predictive factors. So prognostic factors, we focus on things like odds ratios or relative risks, measures of discrimination and calibration. Predictive factors, there's a lot of emphasis on interaction coefficients. You know, how does this predictive factor modify the effect of your intervention? Things like distribution of individual intervention effect, and then relatedly the percent who would be recommended the intervention based on the factor. If you have a factor where, you know, everybody's going to be recommended the intervention or nobody is, that's not a very useful predictive factor. You'd like something where some subset of your population will not be given the intervention based on your factor and some will. Often, you know, when we're developing predictive factors, we do evaluate things like discrimination and calibration because these are at their heart models to estimate risk with and without the intervention. And so we do want to do a good job of estimating risk. And it's important to have data from a randomized trial, which makes this much more challenging than just traditional prognostic scores or prognostic factors. Because, you know, if your overall intervention effect is estimated with bias, then your interactions will be estimated with bias. So you have to start off with data from randomized trial. You can do things like inverse probability weighting and whatever to try to recover that. But it's a little bit, the point is a little more complex than just evaluating a prognostic factor. So now I want to transition to thinking about scores, prognostic and predictive scores. And this is very well accepted in the prognostic setting, but I think people are a little bit slower to come to in the predictive setting. So of course, if we just have one factor, right, one biomarker is really not enough to estimate risk. Or we need to identify who should or should not get an intervention. So there's this fixation again in oncology of like, we just need to identify the predictive marker. And there's very little consideration for maybe we should combine several markers to develop some sort of predictive score. So I would argue that overall there should be interest in creating both types of scores. So prognostic scores, you know, you create a score to estimate risk, something like framing a risk model where you take lots of different factors, you weight them in some fashion, you add them up and you get an estimate of risk. Likewise, I would argue that you should combine predictive factors in some way, weighting them in some way, and then use that to estimate the individualized intervention effect. So just really quickly, again, I think a lot of us are familiar with developing prognostic scores, but I just want to go over this briefly. So typically prognostic scores are developed by fitting a regression model, often logistic regression. You estimate a weight for each factor, and then you get the score in blue. That would be your prognostic score that can be used to estimate risk. And this prognostic score can be developed in an external data set or in a randomized trial. It's recommended that if you are using randomized trial data, you combine the arms. There's this interesting paper by Kent that argues that if you just develop it amongst your control arm, then you're sort of can perpetuate biases. A talk for another day, but you can get this in different ways. For predictive scores, what a lot of people do is just use a prognostic score as a predictive score. So they might just take for the prognostic score S prog, plug it into a model where you have the main effect of your intervention X, the main effect of the prognostic score, and then their interaction. This is what's called the risk modeling approach, described in this PATH statement that came out a few years ago, predictive approaches to treatment effect heterogeneity. And so this is a very common approach. The thought being that, things that maybe put you at higher risk of an outcome, maybe also correlate with effective an intervention. I would argue slightly less compelling because it's agnostic to your intervention. And so you would think there are some maybe intervention specific factors that might dictate how well somebody responds to an intervention. So the other challenge with this risk modeling approach is, and it's sort of related to what I just said, is that it assumes that for each factor in your score, the main effect of the factor is proportional to its interaction effect, with the same constant proportionality holding across all factors. So this is unlikely to hold, particularly as the number of factors increases. So this has been investigated in the setting of genetic risk scores, which we'll talk about later. And there, when you're talking about potentially like millions of genetic markers, it's unlikely that the same constant proportionality will hold for all of your genetic markers. So an alternative is to fit a model with the main effect of each factor, the main effect of the intervention, and then the interaction between them. And so that's what's shown here with the logistic regression model. And you can see in blue, that's basically a prognostic score amongst people in your control arm or your standard of care arm. And then in purple is your predictive score. So those, you take those sum of the Z's weighted by the alphas, and that would be your predictive score, which would help inform your individualized treatment effect. And so then you get the form shown down there where I write the prognostic score amongst the control arm as S prog given X equals 0. And then you have the main effect of treatment, and you have the interaction between the predictive score and X. And this was also suggested in the PATH statement by Kent, and it's called the effect modeling approach, but it's less common in practice. So under this effect modeling approach, then your estimated risk, if someone's in the control arm, X equals 0, is just that prognostic score in the control arm. But if they're in the intervention arm, their risk is a function of that same prognostic score in the control arm, plus the main effect of treatment, plus the predictive score. And so those two together, the gamma plus S pred, that would be your individualized intervention effect. So S pred really characterizes how an individual's intervention effect varies around some population mean. Okay, so evaluating predictive scores. Once we develop these scores, of course, we have to evaluate them in independent data. It's same story as with prognostic scores, the same data, you have some optimistic bias. And a key metric in the evaluation of predictive scores, as I alluded to earlier, is the interaction odds ratio. So if we have the scores I discussed earlier, we have this prognostic score in the control arm and the predictive score. Then in independent data, we might fit this model where we have a main effect for the prognostic score in the control arm, main effect for the intervention, and then the interaction between our predictive score and the intervention. And we're interested in this beta 3. I'll note that one challenge is that this interaction odds ratio is not easily interpreted on its own because there is no main effect of the predictive score. So you can't really talk about, what is the effect of the intervention for a certain predictive score versus a sort of a one standard deviation higher, because you're also changing that prognostic score at the same time. So it's not ideal, but the point is that you can determine significance of that theta-3, which is informative. And then you can use that theta-3 to estimate individualized intervention effects, which are also informative. So like I just said, the individualized intervention effect can be derived from that model. And so that would just be a function of theta-2, which is that main effect of the intervention, plus theta-3, the interaction times the predictive factor. If in moving from your training data to your independent test data, there's no issues of overfitting or generalizability and everything's perfect, then you would end up with a form down here where theta-2 would be equal to the main effect that we saw in the training data, and theta-3 would be equal to 1. So again, I mentioned that there's some special considerations in developing a predictive score. So one thing that we're really interested in is the proportion of individuals who experience a benefit from the intervention when the score is used to guide intervention use. So if the idea is that we're only going to give the intervention to individuals who have an individualized treatment effect less than 0, they see some benefit, a reduction in risk under the intervention, then we would want to know the proportion of individuals who achieve this cutoff. And we also would like to know how valid our predicted risks are that we're estimating from this model. So if the idea is that you want to give somebody an estimated risk with the intervention, estimated risk without, the difference of those being their individualized intervention effect, you also want to know that those individualized risk estimates are accurate. So you do arguably want to look at discrimination and calibration of those models. For folks who are not familiar, discrimination just meaning how well the model separates those who do and do not experience the outcome, and calibration being a measure of how well the observed abilities agree. Likewise, you would like to know if the, there are also, in addition to these traditional measures of discrimination and calibration, which are just standard from prognostic modeling, there's also newly developed specialized measures for individualized intervention effects. So there's a proposal to look at discrimination, where now the question that discrimination, or the thing that the discrimination is trying to estimate, is the degree to which the model correctly rank orders the probability of benefit. So it's asking the question of, do individuals with a lower estimated intervention effect have a lower probability of benefit? This gets a little tricky, right? Because you don't observe outcomes for people under every intervention setting. So you have to get into thinking about potential outcomes, and it's a causal inference framework. So it's a little bit more complex than invalid discrimination in the prognostic model setting. Calibration, to my mind, is a bit more straightforward. It's just the agreement between the estimated intervention effect and the observed intervention effect. It's still tricky because we are not observing intervention effect for each individual. So you're still coming under this idea of potential outcomes, but I think the discrimination is a little bit more complicated because you, rather than a traditional prognostic model where either you do or you don't have the outcome, you can either have benefit, harm, or no effects. So now we're talking about like a 3-level outcome. So it's, to me, discrimination is a little bit more complicated than calibration in this setting of individualized effects. Okay, so now I'm going to move to talking about polygenic scores. So polygenic scores, many people are probably aware, are simply a tool to combine potentially many single nucleotide polymorphisms, or SNPs. They can have dozens of SNPs or millions of SNPs, anywhere in between. And they're typically weighted linear combinations of SNPs. They can be much more complex than that, but for our purposes, we'll think of them as just linear combinations. And we'll focus on 2 varieties. The first is polygenic risk scores, or PRS, which I think are familiar to many people, where the SNPs are weighted by the association between the SNP and disease risk, so like the log odds ratio. And this score is meant to capture sort of overall genetic susceptibility to some disease. There's also predictive polygenic scores, or PPS, where now the SNPs are weighted by the association between the SNP and the effect of the disease risk. So pretty clearly, PRS are prognostic scores and PPS are predictive scores. PRS have been evaluated in several clinical settings as tools to guide intervention use. So this is the risk modeling approach that I talked about earlier, where people just take a PRS, they include its main effect, they include the treatment main effect, and then the interaction between the two. But there's a question of how much is lost in doing this. How much the question is, in the context of polygenic scores, how much is lost by doing a risk modeling approach versus an effect modeling approach? And I would argue, as I alluded to earlier, that since polygenic scores can combine thousands or even millions of SNPs, that this assumption that the main effect of each SNP is proportional to its interaction effect with that same constant proportionality across all SNPs seems particularly untenable. And there was an interesting paper a few years ago that looked into this and showed that, yeah, this is generally not expected to hold for given the genetic architecture of most chronic diseases. But there have been very few comparisons of PRS and PPS for intervention selection in real data. And these interventions have largely focused on just interactions without considerations of how these scores might be used clinically. So a lot of times when people are doing these types of analyses, they evaluate the interaction, they stop there, and they don't look at what the individualized intervention effects are or how this might affect individuals who would be using it clinically. So I'm going to talk about an analysis we did in the Prostate Cancer Prevention Trial, PCPT, which was a randomized trial of finasteride for the prevention of prostate cancer. This study was started 25 years ago, so it's a very old study now, but this was back in the age, at least in the US, where we were willing to do like really big randomized prevention trials, which no one wants to do anymore. And so it was a really groundbreaking trial at the time, and it enrolled 19,000 men who were 55 years or older with a normal rectal exam and a PSA below a certain threshold. And participants were randomized in a 1-to-1 fashion to finasteride or placebo, and they received that for 7 years. Study participants every year had an annual PSA test and rectal exam, and then if the follow-up biopsy was indicated, they had that as well. And then, they had this very nice thing where at the end of the study, everybody had to have a biopsy to determine if they had prostate cancer. So there was a pretty good certainty by the end of the 7 years of whether or not you had prostate cancer. And sort of in a very unexpected twist of events, the primary analysis found that finasteride was protective for the risk of prostate cancer. It was like a reduction of like 25% in the risk of prostate cancer, but it increased the risk of diagnosis of high-grade prostate cancer by like 20%. So it was essentially abandoned as a prostate cancer prevention tool, but it makes for interesting analyses post hoc. So in this analysis, we focus on the outcome of the binary outcome of prostate cancer diagnosis during the 7 years trial. And we focus on about 7,800 participants who were of European descent and for whom genetic data were available as a result of earlier genotyping effort. So most, like 98% of individuals who do not have genotype data don't have it because they didn't submit a blood sample. This was optional. Now we always get blood samples. 25 years ago, we didn't. But of those who had genotype data, 92% were of European descent. So this focus on European descent participants does not exclude many people. I'll just note that all models adjust for the first 5 European ancestry principal components. It's not written out in the models, but it's there in the background just to remove some clutter. So then the question is which SNPs to include, and we took a kind of narrow view and we just looked at 198 prostate cancer risk SNPs. I'll touch on this later. We could have considered a much broader view of other SNPs that we think might be specific to finasteride. But just as a starting point, we have 198 prostate cancer risk SNPs, and we're going to include them in the PRS and the PPS just with different weights. And we found these SNPs based on a recent polygenic risk score published on the Polygenic score catalog. So the Polygenic score catalog, if you've never used it, for every polygenic score, it includes the list of SNPs and the weights for each that were published, generally based on some large GWAS. And so we refer to this published PRS, those SNPs plus their published weights, as PRS catalog. And just a quick note for folks who are maybe don't work in this area as much. I didn't until like 5 years ago, so this would have been foreign to me. But genotyping is done on different arrays, especially again when this genotyping was done was like 15 years ago. The arrays were a bit more specific and custom built, and so typically do not include all known SNPs. And so we used top med imputation to impute the genotype data. Okay. We split the data into training and test data. I'll get to some of the challenges of that at the end. But in the training data, we estimated the PRS. So the PRS that we estimate in our training data, I denote as PRS underscore PCPT, being different from PRS catalog in that the weights, the betas are estimated in the PCPT data. They're not the published weights. And then we also estimate the PRS amongst the control arm and the PPS down at the bottom. So again, for individuals randomized to finasteride, risk will be a function of PRS in the control arm plus the PPS. And for individuals randomized to placebo, risk is a function of just the PRS in the control arm. In the training data, we fit 3 models to assess the interactions between the PRS and the PPS. So again, in the training data, we constructed this PRS PCPT and then the PRS in the control arm and the PPS. So in the first model, that's the PRS catalog. And so that was developed in external data. We looked at that interaction coefficient alpha 3. For the next 2, the PRS PCPT and then the one with the PPS, we would expect some inflation in those alpha 3 coefficients because we used the PCPT data to develop those scores and now to test their interactions. Especially we expect inflation in that alpha 3 for the PPS, and we'll see that in a moment. And then the test data, we fit exactly the same models, but now obviously we've constructed those the PRS PCPT and then the PPS in the training data, so there should be some measure of independence between the 2. So then in the test data, we also estimated the AUC and the calibration slope and intercept for each of these 3 models. We're trying to get at discrimination and calibration for these models. And again, calibration slope and intercept reflect the agreement between predicted and observed risk. And then AUC and calibration, we looked at these overall, and we used a bootstrapping procedure to account for bias from fitting these models in the test data and to generate confidence intervals. We also did implement the calibration of the individualized intervention effect estimates, but we have not yet implemented the bootstrap procedure to account for optimism in that measure. That's coming, but it's informative, I think, and interesting to look at anyway. So based on this, we estimated, based on those models I showed you with the interaction terms and the test data, we estimated an individualized effective finasteride on both the risk difference and odds ratio scales. And we also estimated the proportion of individuals who would be recommended finasteride based on their polygenic score. And this is compared to the default of recommending finasteride to all individuals, given that for overall prostate cancer, finasteride was protective. We do have an analysis looking at high-grade prostate cancer that I won't go into today, but for the purposes of this analysis, we're just focusing on all prostate cancer. And again, we have a bootstrap procedure in the test data to get confidence intervals on this proportion. Okay, so just really quickly, some of the results. So this is an overview of the PCPT data that we used. So there were about 3,800 in the finasteride arm and 4,000 in the placebo arm. It seems that people's willingness to give a blood sample was not the same depending on which arm they were randomized to. But the age and race and everything was pretty similar between finasteride and placebo for those who gave the sample. So you can see that here for age. And then we have about 534 prostate cancer diagnoses in the finasteride arm and 809 placebo arm. And the training data was about 5,200 participants, and the test data was the remaining 2,600. Okay, so first I want to just compare the SNP weights in our different scores, because I think it's interesting. So all the way on the left, we have on the y-axis, we have the weights in the PRS developed in the PCPT data. And on the X, we have the SNP weights from the PRS catalog. So you can see that there's some correlation there, but it's not super strong. We then move to the middle plot where we see on the y-axis the SNP weights for the PRS in the control arm versus, again, the PRS catalog weights on the x-axis. We see much stronger agreement, which makes sense because presumably the PRS catalog, that GWAS, did not have many people in it who were taking finasteride. And then all the way over on the right, we have the relationship between the SNP weights and the PPS on the y-axis and then the SNP weights in the catalog. And we see really almost no correlation, which I think speaks to this idea that even amongst the same set of SNPs, the weights in the PPS would be expected to be very different from the weights in the PRS. Okay, so this is kind of a busy table, but I'll try to touch on the high points. So the first row is the interaction odds ratio estimated in the training data, and I said that we would expect that to be estimated with a lot of bias, and indeed, it's about 1 for PRS catalog and the PRS developed in the PCPT, and it's 3 for the PPS, which is very large. And then you can see when you go down to the next row that when we go into the test data and we evaluate that again, we see a substantial drop in the interaction odds ratio for the PPS. It's still significant, but it's much more within the realm of what you would think would be plausible. The overall AUCs were very similar across the 3 models, which makes some sense because they're including, similar factors to predict risk. But in the interaction coefficients are not huge, so you wouldn't expect that to have a huge impact on the overall AUC. The calibration intercept is similar, slightly better for PRS catalog. Not perfect. You would hope calibration intercept is 0, so there's room for improvement there. And same thing with calibration slope. Not terrible, but you would hope that would be 1. And I think that both of these speak, and even the modest AUC speaks to the fact that if we really wanted to develop a risk model for prostate cancer, we would include a lot of other clinical factors, which we have not included here. So then the last 2 rows are this new calibration intercept and slope measure specific to individualized effects. And I include the asterisk that these are apparent, they're not optimism corrected. And I hope that something funky is going on with PRS catalog, because again, it's the same thing where for calibration intercept, you would hope that would be 0, that there's no sort of overall bias in your estimated individual intervention effects. And calibration slope, you would hope would be 1. So again, these need work, they need to be corrected for optimism, but I think it is informative that, the PRS catalog, provided that these are correct, is a horrendous job. The PRS developed in PCPT does better, but still not great. And then the PPS, again, better, but still not perfect. So we're seeing an improvement, but I think this points to the fact that it's important in these scores. We can't just have a PPS dictating who gets or does not get finasteride. There are like other clinical factors, maybe other SNPs that are not just prostate cancer risk SNPs that have to be included. So it's nice to see an improvement, but it's still not something that I would take and advise people to use clinically. Okay, and then the individualized intervention effects. So these are the individualized odds ratios. So again, an odds ratio of less than 1 would indicate benefit from finasteride. So for PRS catalog in the PRS developed in PCPT, we see that no individuals are estimated to have a benefit from, all individuals are expected to benefit from finasteride. Everybody's below 1. But on the right, the model with the PPS, about 12% of individuals are expected to be harmed by finasteride and should not be recommended finasteride. And that's also the same thing as seen in the risk difference. It's just the distributions aren't as nice because we didn't fit a model for the risk differences. But you can see that for PRS catalog and PRS PCPT, everybody sees a risk difference of less than 0, so they experience some benefit from finasteride. But for the model with the PPS, about 12% of people are harmed by finasteride. Okay, so we performed an analysis to illustrate differences between polygenic risk scores, which are a type of prognostic score, and predictive polygenic scores, type of predictive score, as tools for intervention selection. And we used data from PCPT, which is a large randomized trial of prostate cancer prevention. The hiccup here is that we have no way to validate these results because we have no other randomized trial of finasteride or even any other large observational data in which many people used finasteride, where we could try to recreate a randomized trial. So this is really more of a fun data illustration than something that would be used clinically. But importantly, we focus on measures beyond interaction coefficients and use bootstrapping to account for resubstitution bias for most of the measures and estimate confidence intervals. And I think it's good to see that in the last few years, you know, there's been more interest in making these comparisons and coming up with measures that are specific to predictive scores to evaluate them. And so I think it's important to incorporate that and not just rely on interaction coefficients. So the results of the PCPT analysis indicate that the PPS may be more useful than the PRS from the catalog or the PRS from PCPT in guiding finasteride use. Again, it's not possible to externally validate these findings, but I think that the patterns here may apply more broadly. I'll get to that in a moment, but I think that it's still a useful illustration. And then, as I mentioned, we focus on a set of prostate cancer risk SNPs. There are probably other gains to be offered by considering other SNPs, maybe SNPs related to like drug metabolism, how finasteride, which influences hormone function, you know, how maybe hormone pathways would be implicated. And so I think considering wider set of SNPs would get us a lot farther. And then again, performance would likely improve in the inclusion of clinical factors. As I alluded to, whether or not these findings apply beyond the finasteride prostate cancer setting remains to be seen. I think that there is generally some benefit, but this will depend on the nature of the risk factors available, including the genetic architecture of the disease and the intervention effect, the size of the study, the population being studied, and so forth. I think that, you know, I think one of the key takeaways from this is that I think that we need to move away from folks just saying, I'm just going to take a PRS off the shelf and see how well that can do in guiding intervention use. I don't think that that will be sufficient in most areas. Future analyses in this area should incorporate relevant measures of model fit, particularly calibration of the individualized intervention effect. I mean, that's really like to me, that's the end product that we'd like to give to the clinician or the user is their individualized intervention effect. And so we really need to make sure that we're estimating that super well. And then there's some methodological work to be done here. Some of this we're going to be attempting to do in the next year, but we need systematic evaluations to understand, you know, the impact of overfitting and the magnitude of optimistic bias. This has been very well studied in the setting of prognostic models, but it's less well understood for predictive scores. And then we also need to understand scenarios in which a predictive approach offers gains over a prognostic score. So I mentioned that there's been some work on this restricted to genetic scoring. So looking at polygenic risk scores versus predictive polygenic scores, but I think we need to look at it more broadly in the, you know, predictive scores versus prognostic scores. And then we also need methods for addressing optimistic bias and the evaluation of scores for intervention selection. You know, we've been using a bootstrap procedure to do this, and I'm assuming that that's probably fine, but we need to have a formal evaluation of whether or not that actually addresses that bias. So thank you for your attention. I think we have plenty of time for questions. I'll just highlight some of the papers that were influential in this.
Okay, so thank you.